All these have been able to give overall survival benefit of maximum of 2 to 3 months, and there is no actual data for using anything which is going to give you a prolonged survival. So now we'll come back to a lesser aggressive variant of a thyroid cancer, which is the medullary carcinoma of thyroid. So medullary carcinoma of thyroid is, as I told earlier, arises from the parafollicular C cells. It has a male preponderance and it is generally having family history. So since it is arising from the parafollicular cells, it is generally located posteriorly as compared to the normal uh, thyroid malignancies and normal thyroid swellings. And because of its posterior location, it is generally involving the nerve. So nerve will be more commonly associated, involved in a medullary carcinoma of thyroid. And in FNAC, they generally don't give a diagnosis of sure shot malignancy like PTC, because Bethesda 6, which is a sure shot PTC, is not being given this. In this, Bethesda 5 is the maximum FNAC report that they can give, because it is malignant but not PTC. So they will not be giving a Bethesda 6, which is supposed to be malignancy. And the thing about medullary carcinoma of thyroid is that it is familial in nature. So I'm sure a lot of you would have uh, read or heard about Men syndrome, which is along with the medullary carcinoma of thyroid, there will be some other um areas which are involved, which will categorize them into Men 1, Men 2A, or Men 2B category. So when it is associated with pituitary adenomas, parathyroid adenomas, or hyperplasias, and pancreatic neuroendocrine tumors, it is generally Men 1. Men 2A will also have parathyroid anomalies, medullary carcinoma of thyroid, and pheochromocytoma. So pheochromocytoma generally presents as labile hypertension and early age hypertension symptoms, and they should be treated along with that. So we have operated a patient. We found a medullary carcinoma, but he was having pheochromocytoma, so he had to be operated for adrenal first as compared to the thyroid carcinoma, even though the pheochromocytoma was benign, because the pheochromocytoma was not allowing the BP to be controlled for us to undertake the medullary carcinoma of thyroid. Of course, parathyroid carcinomas can be hyperplasias or adenomas can be dealt with at the same time as the thyroid, because they are in the same field. Meant to be, of course, with medullary carcinoma, you will have mucosal neuromas and Marfanoid symptoms, and you'll be able to make out their habitus. So the workup for medullary carcinoma of thyroid, once you suspect, becomes a bit different, because you have to do a serum marker first. You generally don't do serum markers for papillary carcinoma of thyroid before you undertake for surgery. But in medullary carcinoma, you have to do serum markers, because you will get an idea about where all the disease is. Generally, if it is confined to the thyroid or to the neck, into the nodes, it is generally within 1,000. The serum calcitonin level or CEA level will be quite low. But as the disease progresses and mediastinal nodes or lung mets are present, which may be asymptomatic, but it may be seen in a raised serum calcitonin and CEA levels. So at that time, just doing a CECT neck might not be sufficient, and you will have to go for a Dotonox scan and see where all the disease is prior to undergoing the surgery, because that will help you to know how to counsel the patient that this surgery may not actually cure him completely, but it will be palliative for him and disease will still be present in the metastatic lesions. Urinary metanephrin is generally done to rule out any pheochromocytoma. So once you have diagnosed or uh, evaluated the disease, and once your workup is done, your surgical treatment would be to do a total thyroidectomy with central neck dissection, and also bilateral neck dissections level 2 to 5 is generally uh, taken up even if the nodes are negative on imaging, because there may be micro metastasis which is not generally amenable to radioactive iodine, as in papillary carcinoma, or it is not even amenable to radiation. So for that reason, doing a prophylactic neck dissection is generally considered in medullary carcinoma thyroid. So basically, you have to remove all the neck nodes from level 2 to 5. Sometimes because if it is infiltrating the trachea or the larynx, it might require laryngectomy also. And if the patient recurs, or if the patient has a metastatic disease to start with, which is not operable, like sometimes if there is a mediastinal node or multiple mediastinal nodes, we can do a VATS procedure and thoracoscopic guided, we can do the metastectomy there also. But still, some people may not be always amenable for resection complete, so we have to go for medical management, in which cabozantinib is one of the first line treatment which is generally given now. Second line TKIs, that is tyrosine kinase inhibitors like sunitinib, sorafenib are also considered. And for refractory disease, then only static techniques like external beam radiation is given, and that is only palliative so that the rate of growth is controlled.